slight change of in the program and have Dr. Pablo Gomery speak now, since he has a waiting room full of patients who are waiting for him. And we're going to continue with the topics that we usually don't hear about in neurologic disorders, whether it's the siblings. In this case, he's going to talk about bladder problems and the urologic issues that he encounters. And he's been a great resource to all of my patients, and I'm very grateful to him. So thanks again for coming, Pablo.
So I'm going to talk to you a little bit about what we know about bowel and urinary tract function or dysfunction in ALD. And this may be a little too simple or too complicated, because obviously you all come from different backgrounds, so don't hesitate to stop me if you feel that I'm not making sense. Basically, the lower urinary tract functions in only two ways, very simple ones, which most of us don't think of it that way. It's either for the purpose of storage, which occurs through a process called accommodation of an increase in volume without a rise in pressure. The bladder starts to fill, but the pressure stays the same. And that occurs through passive elastic properties of the bladder wall, as well as the ability of the smooth muscle in the bladder to maintain constant tension. And of course, this is all coordinated via neural reflexes, which controls smooth muscle tension over that wide stretch. The other function that we all think about is the voiding function, where you get urethral and sphincter relaxation prior to contraction of the muscle. And that's very important. They occur almost simultaneously, but not quite. First, the urethra and the sphincter relax, and within a split tenth of a second, the bladder muscle contracts, the detrusor. And at the same time, you get simultaneous relaxation of the pelvic floor muscles. The neuronal control of this whole function goes via a series of central and peripheral pathways, which coordinate both bladder and the outlet mechanisms. They control bladder relaxation, which is what we call compliance, which is the ability of the bladder to accommodate volume. The bladder is a wonderful sensory organ. It senses fullness, and it converts that mechanical energy as it distends into electrical energy that sends off signals to the spinal cord and the brain. It maintains continence with increasing fullness, and it initiates voluntary voiding. The various phases, this gets a little complicated. The storage phase is controlled through the sympathetic system, which originates in the spinal cord between T10 and L2 via the hypogastric nerve, and the neurotransmitter is norepinephrine. The voiding phase is controlled by the parasympathetic system through S2, S4 origin via the pelvic nerve, and acetylcholine is the transmitter. And then there's also the somatic control, which comes via S2, S4, which controls the pudendal nerve, which controls your ability, which gives you ability to control your sphincter muscle, and that's via acetylcholine also. In a simple way, so what happens when things aren't going well in dysfunction, the pathophysiology? So again, in trying to keep it simple, you think of it as problems with the bladder, problems with the outlet. The bladder can do one of two things, or the bladder muscle, if you will. It can be overactive, meaning spastic, or it can be underactive. The outlet also can give increased resistance or decreased resistance. The various disorders that give either of these problems can be either neurogenic, like in spinal cord injuries, multiple sclerosis, any of the demyelinating diseases, Parkinson's disease. And then there is myogenic, which is problems with the muscle of the bladder which occur. And we're also learning over the last 15 years that because the bladder is such a complex organ that we really didn't know, there are all sorts of neurotransmitters constantly communicating between the various tissues of the bladder, along with then going to the afferents, going to the spinal cord. And the bladder can become also underactive for various reasons. And the interesting thing is that oftentimes, if you think about it as an analogy to congestive heart failure, the bladder is also smooth muscle that contracts. The heart is smooth muscle. And as the muscle tries to compensate for some problem that's occurring, voiding dysfunction, what ends up happening is that the muscle gets hypertrophied, but it eventually starts to fail. Just like that term that you've all heard, congestive heart failure. We don't have a term for this, but it's the same thing, it's bladder failure. And so you can go from having an overactive bladder to an underactive bladder, or a hypotonic bladder, or then an atonic bladder. And then the outlet, the important thing about this is that the outlet itself can give you increased resistance or reduced resistance. It can be either anatomic or functional, meaning something's wrong with the actual structure, or it's functional. And what's important here, what I really want you to pay attention is this term, detrusor sphincter dysinergia, because we think that this is what happens in ALD quite often, because it is a spinal cord demyelinating disease. So what do we know? We know very little. There are only really in the whole literature 2 half-decent series that have been compiled to study this whole problem in kids with ALD, ADL people. So this particular study, which was just published this last March, and it's out of Germany, and this group in Germany, but also some people from London, from the neurourology group at Queen Square, which is very, very involved in the research of all this neurourology. So they took 19 males with adrenomyeloneuropathy and 29 female carriers. Obviously they took the adrenomyeloneuropathy patients because they're the most common phenotype. And it turns out that in the whole world literature, this is the largest group reported. And what they did was they used standardized validated questionnaires, which they sent out to these patients. The urinary symptom profile, the quality in short form. I'm not going to go into the details of each of these because they're quite thorough, but they're obviously all very robust, validated questionnaires. The International Prostate Symptom Score, which is really a test of a questionnaire that talks about urinary symptoms, and then the neurogenic bowel dysfunction questionnaire. And 84% of the males that were interviewed and 55% of the females had moderate or severe bladder storage symptoms. We talk about symptoms in the urinary tract. The urinary tract has very few ways to talk to us about what's wrong. If it's we call voiding symptoms, things like intermittent stream, poor force of stream, hesitancy to get the stream started, a feeling of incomplete bladder emptying. And we talk about irritative or storage symptoms as what usually people refer to as frequency, urgency, and urgency incontinence. So this group took the adrenomyeloneuropathy males and looked at previous case reports, which is all that's available. And they found out that what is available is that there is urodynamic, which is a test in the lab to see how we can reproduce your voiding function or dysfunction. And what there was in the literature is basically that these are overactive bladders, an overactive detrusor, and there was a suggestion that this is also being complemented by detrusor sphincter dysinergia. But what was really interesting for them was that of all the patients they talked to and studied, only 1/3 were really receiving treatment for their lower urinary tract symptoms at the time of the study. And that's not surprising because there are so many other body systems that are involved that overwhelm the urinary and bowel, but they are significant. So what is this detrusor sphincter dysinergia? It's a really interesting phenomenon. It's a detrusor contraction, which is concurrent with an involuntary contraction of the outlet, the urethra and periurethral striatum muscle. This is the definition of the ICS, which is the International Continence Society, which is the governing body that decides on all these definitions. It, of course, has to occur in suprasacral demyelinating lesions, spinal lesions, because essentially what you get, since I told you that you get when those of us who urinate normally, we get simultaneous, almost simultaneous contraction of the bladder muscle and relaxation of the outlet. This is what dyssynergia is. You don't get that simultaneous contraction and release of the outlet. What you get is contraction and contraction of both at the same time. So the sphincter intermittently opens and closes during the voiding phase, which it shouldn't do. And when it closes and the detrusor muscle, the bladder muscle is contracting at the same time, obviously the detrusor pressure rises because it's contracting against the closed sphincter. So what does that mean? The consequences are you get increased intravesical voiding pressures, which can lead to bladder trabeculation, which is hypertrophy. Bladder trabeculation is the same thing as what happens to the heart as it tries to contract against hypertension or against an aortic valve that's causing blockage. And it also then leads to formation of saccules or diverticula, high residuals in the bladder because you don't empty fully, higher risk of urinary tract infection, and then a pop-off valve. The way the bladder pops off, as it pops off urine going north to the ureters and the kidneys. But the problem with that is that eventually, if the pressure is high enough, you can get deterioration of the kidneys. So what about the female ALD carriers? Though they carry only one copy of the mutation and should not express the phenotype, what these people showed is that they have symptoms also. They have all the neurological symptoms, and they actually began to study what bladder and bowel symptoms they were having. And interestingly enough, these carriers also showed the same storage symptoms, similar in severity to the males, and with comparable neurological disability. As far as bowel dysfunction, the symptoms also were apparent in both male and females, but they were less common than the urinary symptoms. But some patients did express that they had severe bowel symptoms. And there are the numbers in terms of bowel complaints, which were predominantly constipation. So this is another study that actually came out before that, where this is a study that was done out of Rome, Italy, now 11 years ago. And all they did was they compiled a series of patients going from 8 to 53 with ALD that came to their urodynamic laboratory for testing. So as you can see, they compiled various phenotypes: adrenomyeloneuropathy without cerebral involvement, 3 with adult cerebral involvement, 3 with classic childhood cerebral form, 1 with adrenomyeloneuropathy with cerebral involvement, and 1 who was totally asymptomatic neurologically. And instead of using the more modern questionnaires that the other one used, obviously, they used what's called the International Consultation and Incontinence Questionnaire, which is a short form. And they gave the patients a 3-day voiding diary to fill out. They divided the patients in 3 groups depending on severity. The first group was, and it's obvious you can see there are very few patients. The first group is 3 patients, had no urinary symptoms, had a very low score on the questionnaire, and they did no workup. They didn't do anything. The second group were patients who had frequency and urgency, had a higher score on the questionnaire, and all they did was watch their urinary flow rate. We have these special machines that we can observe how people urinate, and we can make some commentary on that, and they did a post-void residual. And the third group, which was the largest group, 7 patients who did have voiding symptoms, incontinence, higher score, and they did a urodynamic study. In the second group, they found a couple of patients that had a normal study with it maybe an intermittent pattern, which that's the pattern that you would expect in the detrusor sphincter dyssynergia, because remember the sphincter opens and closes continuously, so you get almost a systolic wave pattern. And one of the patients had a high bladder capacity. In the third group where they did the urodynamic study, 6 out of the 7 had the detrusor sphincter dyssynergia, which is perhaps significant, but we're talking about really small numbers, and this is all we know in the world literature. And then there was one patient who had a detrusor, an underactive detrusor, which may be what I told you at the beginning, that that patient may have started as an overactive detrusor and finally the bladder muscle failed and it became hypotonic. And this was the conclusion of the author, which is interesting. The hallmark of ALD is changing neurological behavior with varying clinical symptoms, usually in stepwise progression. Urinary symptoms, when compared to the cascade of endocrine and neurological devastating effects of this quickly progressive disease, may be neglected during evaluation and treatment. Thank you.
So, Pablo, before we get to questions, how do you treat?
I didn't want to do treatment because obviously treatment depends very much on each individual case. But it's important to treat the dyssynergia because we don't want those consequences to occur. So our treatment is limited to two things. One, an anticholinergic, which decreases the spasticity of the bladder, so of the overactivity. And in order to not allow the vesico-ureteric reflux, high voiding pressures, etc., we usually use clean intermittent catheterization. The problem with clean intermittent catheterization is that somebody's got to be able to do it. Somebody's got to be able to do it regularly. One of the biggest problems of intermittent catheterization is that most urologists will recommend it as you do it once, twice, 3 times a day. None of us urinate once, twice, or thrice. So literally, you have to be catheterized as often as you would expect someone to urinate, which is every 2-3 hours, and it becomes cumbersome. But you do need to overcome that sphincter dyssynergia, and that's so far, at this point, the best way we have. In the olden days, we used to do all sorts of horrendous surgical expeditions of totally removing the sphincter. It was horrible. We don't do that anymore.
So beyond Detrol, what can you do?
Well, we treat anticholinergics, intermittent catheterization. Sometimes we have to leave a catheter in, so we use suprapubic tubes. It all depends on what we find. We do have ways of decreasing the resistance of the outlet. Alpha blockers make the urethra dilate. That helps. In cases of underactivity, we sometimes treat with cholinergic agonists like methanochol. It all depends on at what stage we find these things.
So a lot of material there.
You've addressed now the treatment.
Wait.
Just the bowel issue. Cover that. I wonder if you have any treatments for the bowel dysfunction that you mentioned is also present.
Well, I don't do that part of it, but unfortunately, I often have to get involved. And then, in terms of constipation, we do our best to combine all sorts of agents, high fiber agents, stool softeners, laxatives. And then the other thing we do often is we have to always remember that when we treat with anticholinergics, we often create our own bowel problems because most anticholinergics can give you some constipating effect. So we have to be careful with that. But what you have to realize is, clearly from the way I presented this, is treatment of the bowel problems is way behind even treatment of the urinary problems, and the urinary problems is Neanderthal. So bowel is pre-Neanderthal. It's just beginning to be talked about.
I'm wondering if you could speak to 2 different things. One, how exercise might affect some of these issues, and also your experience with rehabilitation. I know there are physical therapists that have some training in pelvic floor treatment, and I don't know what your experience has been with that.
Exercise was your first question, right? We know very little about how exercise affects any of this. I do have to tell you again, I tried to present this as evidence-based. So a few years ago, actually 5, 6 years ago, the International Continence Society that I mentioned, which is a worldwide organization, meets yearly, thousands of people come, decided in its wisdom that it was going to incorporate the Society of Physical Therapy. And the Society of Physical Therapy started to present papers, data. The evidence-based knowledge is almost zero. There's a little bit, but very, very, it's even more prehistoric. Medicine until not too long ago was also not evidence-based. It was really opinion-based, expert opinion-based, which didn't mean a whole lot. And so we're trying to get away from that expert-based so-called opinion to more evidence-based. And physical therapy is still one level behind us in terms of that, though we're trying to incorporate it as part of all this. And I mean, for instance, we have now specialists in pelvic floor physical therapy, but it's a lot of opinion-based, how much they help. In terms of actual data, we know very little.
So are you saying that you haven't seen any positive results? Is that what you're saying? If someone has gone to physical therapy, there's been no improvement?
No, I'm not. Well, I'm not saying that. All I'm saying is I'm trying to stay away from opinion and trying to talk about evidence, because oftentimes, as we found in medicine over the last 50 years since we have begun to do clinical trials, is that what anybody thinks is an opinion that does not necessarily turn out later to be fact. So I'm just trying to stay very based on fact.
So we have a real opportunity here, right, with an ALD Connect. I think this is, sometimes you have to go through pre-Neanderthal to Neanderthal, but we can go straight to the modern times with social media, with Patient Portal. I know people like Joan and others are developing surveys, have developed surveys, and I think having you here in the room, knowing of your knowledge and background, we want to have you be part of our mission to shed light on this. And I think we can do this rather quickly through patient experience and patient reporting. And maybe if you can help guide some of the readouts and guide some of the surveys that we would like to pull from Queen Square and pull from other places, put into layman terms, and develop a little project around that. Katie?
No. One other problem we hear, could you address how you tell the difference between a real bladder problem versus just I had 2 babies in the women? Because oftentimes in clinic people will say, I have a little leakage, but I had 2 babies or I had 3 babies.
Well, basically we do it with urodynamics, which is we try to reproduce how people void, how they store and void, and we try to figure out. But oftentimes that's a very, very good point. What we're learning is that you oftentimes have more than one issue going on. Like, I didn't go through this, but in one of those slides when I talked about anatomic and functional, for instance, you can have a male, for instance, who has what everybody thinks, if you look at a primary care physician's assessment of any urologist's consultation, he'll always say prostate symptoms. To a primary care physician, everything's prostate. Well, it ain't. We're no longer as prostatocentric as we used to be. Thank God, thank God. But that's all they know, so they put prostate. But you can have neurological problems along with prostate, and in a female, the same thing. You can have problems that are truly related to trauma of childbirth, which can be either anatomic, of the muscle structure, of the hammock structure that gives women continence, but you can also have the aging lower urinary tract acting up and causing problems. So it's our job to discern what's what and which is
So either way, they should come see you, because there could be help either way.
Absolutely. But unfortunately, we don't have enough time to see everybody.
Yeah.
That's our problem, is access. It's a huge problem.
You only have to see our patients. So that's fine. So, Alan, please.
Yeah, my problem is growing older with this illness, ALD, it has become a problem. And I have been doing different things with like how I'm eating or like when I'm eating. And so that's becoming a problem, you know, that I'm not able to do things when I want to because of the urgency. So I have to like, okay, I'm holding myself off before I do anything. Is there anything to do about that?
So you have to talk to your doctors, you have to talk to a gastroenterologist. There are now, at least in the big academic centers, gastroenterologists who specialize in the neurological complications or the gastroenterological complications of neurological disease. But there aren't too many of them, but they do exist now, and they're beginning to learn a lot about how that works. And I can't think of anything else to say except talk to somebody, try to find the right resources.
I also think the support groups are great. I think I remember at ALD Life in the UK having a room full of men exchange information on how they deal with bladder symptoms was eye-opening. You know, they each one of them had a different strategy. So you went from really being feeling very helpless to empowered, and I think that kind of exchange is important, and we should try to establish this here. Well, so I've been going to leukodystrophy meetings for 15 years, and this is the first time I've had a urologist at the meeting, so I think let's not wait another 15 years. Let's make sure we have you come every year. So.
My problem is I'm old, I won't be around.
Thanks again, Pablo. Okay.